cannot see you.
Yeah.
Please check your masterclass WhatsApp. Yeah, Febin, please describe the image.
It's a fundus picture of the left eye.
Okay.
Showing along with the arterial dilatation.
Along with arterial dilatation. Okay. Are you sure arterial dilatation you would want to say? Okay, fine. Fine. Arterial dilatation. What's next? Anything, whatever you see.
Every scattered hemorrhagic spots.
Okay. Okay, what would be your diagnosis?
Okay, so it's the hemorrhage is confined to vein occlusion.
Hemorrhages confined to vein occlusion.
The supratemporal.
Supratemporal. Okay. So what would be your
Probably a BRVO.
So you're trying to say it's an STBRVO.
Yeah.
No, I would disagree with you. It's a CRVO. Okay. It's a CRVO. Some things that you did not mention in your description was flame-shaped hemorrhages.
No,
And also you had mentioned that the arteries are dilated. Yes?
yeah.
When in fact it is the veins
It's
that are dilated. It stands to reason that in a venous occlusion, just like how we study in MBBS in a CVC liver or a CVC spleen, the venous congestion will cause a dilated vein, right? So here you can very clearly see the arteries are very thin. Whereas on the other hand, it's a hugely dilated vein, almost
veins.
twice the size of an artery. What is normally the ratio between an artery and a vein? Is something close to 1.3. A vein is slightly bigger than an artery. In in this case, in certain areas, I would say the vein is almost more than double the size. Another thing you could have mentioned is there is you said something like scattered hemorrhages. Uh, did you want to say dot and blot hemorrhages? Is that what you were trying to tell?
Yeah, dot and dot.
Yeah, because dot and blot hemorrhages is present all across in all four quadrants. What would that tell you? What else could this be if there is dot and blot hemorrhages in all four quadrants?
Proliferative diabetic retinopathy.
Yes, this would very well be a NPDR as well. What
Yeah.
will be the differentiating factor which will help you diagnose that this is not a diabetic retinopathy? I can say for sure this is not a diabetic retinopathy. Even though you are right by saying that it looks like diabetic retinopathy, I can say for sure. What is the one question you would ask, or one presentation which differentiates between a RVO and a diabetic retinopathy? The most important. So that would be the sudden presentation, the sudden onset of a RVO, whether it's a BRVO or a CRVO. This picture happens within a span of an hour to 3 hours. This is how the guy starts to look. His retina is perfectly fine 1 second and completely destroyed the other second. Whereas a diabetic retinopathy, obviously, it's like years and years of slow progression. Okay, apart from that, one more important thing you missed is the tortuosity of the veins. The veins are extremely tortuous, which is another cardinal feature. You cannot miss this one. Like the obvious thing there is the flame-shaped hemorrhage. Okay, we had stopped at dot and dot hemorrhages. So the main thing you should have told about the hemorrhage was the flame-shaped nature of the hemorrhage. Okay, that is extremely important, without which you cannot describe a RVO picture. Second thing you should have told was a dilated vein, which you did, but you had mistakenly called it as the arterioles that are dilated. Third thing you should have mentioned was a tortuosity of the veins. Why venous tortuosity is important, or at least to acknowledge it is, there is another very, very important DD which looks like this. Or else at this point of time, I would like you to ask what other differential diagnosis would you say? One is diabetic retinopathy, completely agree with you. But you would differentiate it by taking a simple history from the patient of the onset of the disease or the onset of the loss of vision. What other disease would be your DD? So there are many things. This thing can
Ischemic.
No, that comes under. Oh yeah. Please just complete your answer.
So any ocular ischemic syndromes?
Yes. Ocular ischemic syndrome is the right answer. You have to mention whenever you see scattered hemorrhages, like you mentioned earlier. You have to mention ocular ischemic syndrome as well. There is another thing you can also mention. Here you can also mention radiation retinopathy. Okay, radiation retinopathy also you can mention. Even though you might be thinking radiation retinopathy looks a lot different, I agree, radiation retinopathy has so many presentations. Most prominently, radiation retinopathy is associated with cotton wool spots. Prominent cotton wool spots. Big cotton wool spots are normally the presenting feature for radiation retinopathy. What is another very, very important part in the history that should be there in radiation retinopathy? There should be a history of radiation. There should be a history of radiation. The patient should have radiation. It's common sense, right? The patient has to tell you that there has been a history of irradiation in me in the past. Okay, having dealt with radiation retinopathy, regarding tortuosity, I wanted to talk about ocular ischemic syndrome. Ocular ischemic syndrome doesn't exactly look like this, obviously, but it almost looks like this. There are scattered hemorrhages all across the this thing. But you know what is missing? The most important thing that is missing is tortuosity is not at all there. There is no tortuosity, and the space between the individual hemorrhages is relatively clear. The retina is surprisingly clear between areas of individual hemorrhages, not like diffuse flame-shaped hemorrhages all across all quadrants. Okay. Okay, fine. Having said those DDs, do you remember the causes for CRAO? Like if somebody asks you, what are the causes of CRAO? What is the etiology of CRAO? This is Rajesh sir's favorite question. Causes of CRAO and investigations to be done in CRAO and CRVO. So it's very simple. Alia, you're back. I can't see your video. So whenever you think of CRAO, you need to think of an emboli. Okay. Now you can say all the causes for emboli as the etiology for CRAO. Calcific emboli, you can talk about a fat emboli, you can talk about a thrombotic emboli, you can talk about an atherosclerotic emboli. All of these will stand as individual etiologies, individual entities. Okay, they won't come under emboli. You can name them individually. Apart from that, always it's common, if it's a young guy, it could be a hypercoagulable state. Are you okay, buddy? Seven?
Yeah. Yeah, okay.
Your eyes seem to be watering a lot. You wanna
Yeah, a little.
You wanna close your
Yeah, a
eyes?
little bit water.
You wanna close your eyes for a little bit?
No, it's okay.
Should I turn to Alia?
No, it's fine, it's fine.
Okay. So the thing is, where was I? Yeah. As long as it is a CRAO, you can very easily skip the question by saying all types of emboli as the main reasons. And if it's a young CRAO patient, you have to always think autoimmune diseases such as SLE and hypercoagulable states such as polycythemia vera or protein CNS deficiency. Alia, I still cannot see. Protein CNS deficiency and also factor V Leiden mutation. This way you can tackle the etiologies. Keeping this in mind, when you talk about a CRVO on the contrary, on the other end, all the causes that increase the pressure in the disc will cause CRVO. Okay? All the causes that increase the pressure in the disc will cause a CRVO. Let me tell you how. Hypertension is the cause of CRVO. Optic disc edema can increase pressure in the disc, is the cause of CRVO. Glaucoma can increase the pressure in the disc, can cause a CRVO. Optic disc drusen can increase the pressure in the disc, can cause CRVO. So CRAO, out of 6 reasons, 4 of them are emboli. CRVO, out of 6 reasons, 4 of them are increased disc pressure. Disc drusen, glaucoma, disc edema or hypertension. Along with that, you can also mention atherosclerosis as well because that's a simple thing we will never forget. Once you have mentioned these 4 reasons, you can always repeat hypercoagulable state and also autoimmune diseases. They are both common for both of the vein occlusions and artery occlusions. This is actually an easy way of remembering it. After learning multiple times, this is the pattern I could find in them. One more thing that we could talk about strangely in CRVO is if it's a young girl. Anything strikes your mind, Alia? Does anything come to your mind? If it's a young girl, what etiology? Okay. Yeah, OCP is the correct answer. You can take your time, Alia. Doesn't matter. So, yeah, where was I? Today seems like a really bad day to take class, huh? Nice, tragedies are happening. Okay, anyways, it's a small class. So this is how you approach the etiologies for CRVO. Okay, having done that, would you want to mention this? Do you know the types of CRVO, Fevin?
Fever,
There are only two types.
perfused and
Sorry,
perfused and not perfused.
perfused and non-perfused. Are you trying to say ischemic and non-ischemic?
Yeah.
Okay. Would you want to describe them? What are the main features?
Non-ischemic means, I think non-ischemic is the most common variant, and
Non-ischemic is the most
the,
common variant.
the best corrected visual acuity will be better compared to the other one.
Okay. Would you like to tell some range when you say better? Better than counting fingers.
Better than 6/60 or better.
Okay. 6/60 or better. Okay. Agree. Any other things?
Non-ischemic means the presentation will be usually sudden, unilateral.
So as opposed to ischemic, which could be bilateral and insidious in onset.
No, ischemic means it's sudden, but it is more severe.
Yeah, so I don't think the onset has any difference in both of them. It's rather the intensity or the severity. It's actually you are playing the right game, because if you keep comparing them both of them together, that's very easy way to solve this issue. So ischemic would have, like you had mentioned, something like non-perfusion. So ischemic would have a widespread capillary non-perfusion, whereas non-ischemic would have mild fundus changes. This one is rarer and more severe, whereas non-ischemic is more common, as you had mentioned. Your visual acuity point was correct. Another point I would like to add is RAPD is often present in ischemic, which is a good point. Which is because RAPD is also present in CRVO. It is one of the few times when a retinal pathology can induce an RAPD, as opposed to an optic disc pathology. So the only two places where you very commonly see an RAPD is supposed to be mentioned. So an RAPD would often be seen with a very bad visual acuity in ischemic. That's about it. If you play, just keep comparing both of them, then that's more than enough. The reason being that it is 100% going to be asked. If it's an RVO, he is going to ask you what are the differences between an ischemic. How would you differentiate between an ischemic and a non-ischemic RVO? So just by this picture alone, what would you say? What would your diagnosis be? Which type of RVO? It's actually difficult to say. It's not so straightforward. It could slightly, Alia said it could slightly lean towards ischemic more than non-ischemic, but there are huge chunks of the retina where there is not much diffuse hemorrhage as well. But if you say ischemic, you can get away with it. Nobody is going to hold your collar saying how the hell can you say it is ischemic. It's okay, it's understandable. It's a subjective thing. For now, in the same hospital you might be working, Alia might say it is ischemic CRVO, you might say it is borderline ischemic or non-ischemic. Either way, it's right. But this case is an ischemic CRVO anyway. Now, any investigations would you like to do, Phil? So, Alia
Again,
mentioned,
in FFA,
so Alia mentioned FFA. I would actually advise against, it's not the wrong answer, but I would seriously advise you to go in a very nice sequence. Hardly
CT.
we ever have this FFA as the first test. If you have prepared for USMLE or these UK based tests or US based tests, they always have what is the best test and what is the first test. They have this clear differentiation. So Alia is not wrong by saying that the best test could be performed would be an FFA. Why, I will ask her later. But the best test, the first test would not be an FFA. or the first workup. That's why I use the word workup. So you would start with a ocular examination. You would check the IOP. You would check the visual acuity. You would do a careful slit lamp examination. As always, these things are always repeating. Like find a pattern in all the classes that I've taken for you guys. These patterns have always repeated. Always careful examination. Always IOP. Always visual acuity. Always slit lamp examination. Then you could do a gonioscopy in this case. Okay. Now I would like to ask you, why do you think a gonioscopy is important in an RVO? So Alia just answered NVI and then she wrote the word NVG. Would it be NVG the moment? Okay, what you should have said is NVI is correct. You should have also mentioned NVA if I'm talking about a gonioscopy, because you need to understand that RVO. You need to understand that the RVO is extremely closely related to neovascularization. Okay, and weirdly speaking, CRVO has disc NVD, whereas BRVO has NVE association. It's so strange. Another thing, you cannot call it an NVG. Refrain from calling it an NVG because I hope you guys are there because I can't see either of you. Yeah, Fabit, are you there? Okay. So Alia is here. Refrain from calling it an NVG because we have not established it is glaucoma yet. You have not established a field loss. You have not established RNFL loss. So we would like to refrain from that point. Whereas if you say, I would like to see for an NVA or NVA, you are not at all wrong about that. Okay. So this is how you go step by step. Having done all the things, I can't think anything that comes to mind. Oh, I would also do a fundus examination. I would perform a fundus examination with an anti-D. Then I think yes, I would then go for an FFA. Why would I go for an FFA? Febin, are you with us? What do you mean by perfusion? Okay, so you want to check the extent of capillary non-perfusion. Okay.
Yeah, sorry, that's a call came in between, that's it.
Okay, no problem. So Alia said initially that FFA we would like to do. FFA is the correct answer. It's the best test you could perform in a CRVO, not the first test. Let's make the differentiation. So why would we perform the FFA, Febin?
FFA. We can know how much we can know the extent of obstruction to FFA.
Okay, you mean to say the degree of capillary non-perfusion?
Yeah, if there is any difference in capillary permeability, or we can know from.
Okay, you can just use the word capillary non-perfusion, extent of non-perfusion areas, or NPAs they call them, non-perfusing areas. Rajesh sir writes NPAs. So Alia was mentioning something like more than, I would like to find out if there is more than 10 disc diopter. Did you write on that, Alia? Can you explain why you wrote that? Why do we need to find more than 10 DDs of like 5 areas or 10 areas? Yeah, there is some debate. I don't think it is 10 areas, 10 disc diopters. It is slightly lesser than that. Either way, what you're trying to find mainly is, you're trying to find capillary non-perfusion, and more than that, more than areas of capillary non-perfusion, you are actually worried about the manifestation, what happens because of capillary non-perfusion. What happens because of capillary non-perfusion which you are afraid of? Kevin?
So the peripheral focus can be affected.
Peripheral areas can be affected. Okay, agreed.
Posterior pole.
The posterior pole can be affected. Agreed. The vision is completely gone. Like it's one of the most common causes of complete blindness. Just like CRVO, CF 3 meters, CF 4 meters is obviously the vision is completely gone. I'm not too worried about saving the guy's vision at this point of time. What am I worried about? So capillary non-perfusion will cause a very hungry retina which needs oxygen all the time. It pushes it to produce more blood vessels, which is essentially neovascularization. Okay, so CRVO is actually a topic you guys should be taking very seriously. It is actually quite tricky. There are so many questions that can be asked in CRVO, and it is a terribly simple topic from the outset. But if you dive a little bit inside, it's like a whole world in itself. Because I was about to ask you that why are we even worried about? So Alia said something like capillary non-perfusion areas. If the areas is more than 7 disc diopters, 10 disc diopters, why are we worried about that? Because of neovascularization. But what if there is no neovascularization yet? So first of all, I'll ask you, what is the treatment for neovascularization? Febin? What is the mainstay treatment for neovascularization?
Laser treatment.
Yeah, laser treatment. Which laser treatment? Focal laser? Are you guys sure? Focal laser can be performed for edema. What about neovascularization?
That's PRP.
PRP is the answer. Okay. PRP should flow off of your tongue. The moment you talk about neovascularization, one cardinal thing you will be doing is PRP. PRP, neovascularization, PRP. What is the mainstay treatment for NVI? It's PRP. What is the mainstay treatment for NVA? What is the mainstay treatment for NVD, NVE? Any sort of NV, you have to perform a PRP. Engrave this in your brains. Don't hesitate for 1 second. No need to mention any complicated terms like PDT, focal laser, all these things. This will come later. They are more related to your macular edemas. But as long as NV, it's a very simple answer, PRP, that's it. Okay? Because NV is a very extreme state. We very rarely see NV. We are always afraid of getting NV in any state. So when NV actually does come, we don't waste any time performing a PRP. At that point of time, we are not at all worried about the retina's health. We are more worried about things like retinal detachment, or even further more crazy things like malignant hypertension, or stuff like NVA, which might later on increase the IOP to such a degree that it might induce a NVG. So NV, the moment NV comes in, go ahead and perform a PRP. So actually I was about to ask you, would you perform a PRP if there is significant areas of capillary non-perfusion, or would you wait for NV to come in? Because there is a very, so at this point of time, I think the first time we are ever discussing this thing, we need to know about studies. Okay, there have been some landmark studies. So ophthalmology is very special because we are a very study dependent field. Orthopedics, it's all trial and error. Anybody does whatever they feel like, and somehow it just works out unless it's cutting edge. Then probably we follow the latest guidelines, but most of the time it's like even the interns are half orthopedicians. Whereas ophthalmology, since it is the eye, we don't take any chances, and everything is so new in the eye regarding lasers and anti-VEGFs. We have so many studies, important studies. So CRVO alone has 5 studies. or retinal venous occlusion alone has almost 5 studies, and all 5 studies are important for you to know. I can tell you the year in which the study was done and exactly what the study tells you. Okay. So there was a study done in the year 1985 called BVOS study, and then there was another study done in 1992, I think so, called as CVOS study. In the CVOS study, which is, what is it called? Central venous occlusion study, they found out that it's a long study. I won't bore you with all the details. Ultimately, what you need to know is exactly what the study told you. What the study told us that before time, prophylactic PRP is useless. Never perform prophylactic PRP. These people thought if PRP is so nice for neovascularization, why don't you perform it 6 months before? So what is the average duration after which neovascularization happens in RVO? These are all very important questions. All possible questions that can be asked in a viva or a practical setting. So what is the normal duration after which you expect to see neovascularization in CRVO? 7? Can you hazard a guess? Is it days?
2 to 3 months.
Okay, it's 7 months.
Oh.
7 months is the average duration after which you expect to see a neovascularization. It can be lesser than that as well. I'm talking about the average time. So some people did not wait for 7 months. They thought, why don't we perform a PRP on some very precious eyes, very precious patients? They performed this as well. Ultimately, they found that it is useless to perform this prophylactically. Wait for the earliest signs of neovascularization and then and only then perform PRP. So one way this question can be asked is whether the PRP should be performed or not. This is the answer you should have. And 100% CRVO case you will have much more than the treatment and the investigations. They will talk to you about studies as well. So CVOS study is very, very important. Similarly, somebody had a BRVO also. So will PRP work in BRVO was another question that they had. So they did a study called BVOS study. This was one of the first studies done in 1985. That study ultimately told yes, PRP is very good for BRVO as well if you see neovascularization. Okay, it's a very simple outcome that they had. Since it was the first study, it was something complicated. So don't get confused. The first study is BVOS, not CVOS. In the first BVOS study, they confirmed that neovascularization in BRVO, PRP can be done. In CVOS study, which was done later in 1992, they found out that prophylactic PRP is useless. Don't do PRP before it is needed. Wait for the MD to come and then perform the PRP. This was study CVOS done in 1992. Now there are 3 more studies that are very, very important. These are modern studies. These are modern studies done 10 years back because they deal with drugs that were invented very, very recently. They were invented almost after Al-Salama was started, or sorry, Abid was started. Okay, so they are that new. These drugs are anti-VEGFs. So there are 3 very, very important studies for anti-VEGFs and CRVOs. They are CRUISE study, they are the BRAVO study, and the SCORE study. Okay, these 3 things will come a little bit later on. So where were we? Yeah, so you will perform an IVFA and you would check for leaking vessels. A very important thing we forgot to discuss in CRVOs, which is Opto Ciliary Shunts. Do you know about this, Kevin?
Oh. Hello?
Do you know what are optociliary shunts?
Tortuosity.
Have you heard the name?
The shunt between between retina and the choroid?
Okay, I'll make it extremely simple for you. Even Alia claims to have not only heard the name, not in detail. It is in all essence, okay? It's very simply, it's a new vessel. It is also a neovascularization. But the moment you hear the word neovascularization, you should be afraid and running towards PRP. But in the case of Opto-Ciliary shunts, even though they are new vessels, they are the Opto-Ciliary shunt is an old name. Nobody uses that name these days. They are called as collaterals.
Right.
And there are very famous, most famous type of collaterals is disc collaterals. They look very beautiful all across the periphery of the disc. They come like, like a rim. All across the disc there are. When Rajesh sir sees collaterals, he gets very happy because the retina is dead at this point of time. Whereas a collateral circulation is the good brother of the neovascularization. It is new vessels which do not leak. The very essence of new vessels. We don't hate the new vessels because they are new vessels. We hate them because they are useless vessels. Not only useless, they are actually dangerous. They leak and they cause hemorrhage and they cause other issues. They keep on growing into the vitreous. Whereas collaterals are the good brother of the enemy, which is neovascularization. They do not leak, and in fact they actually supply that part of the retina by counteracting the non-perfusion. They actually induce perfusion. So you should be happy when you see collaterals, sad when you see neovascularization. What is the best way to find out which is which? If I show you a photograph of new vessels and collaterals, can you find out? Maybe you can find out. If you are Rajesh sir, maybe you can find out. But for a normal guy, you have to perform an FFA. You have to see whether the vessels are leaking or not. Okay, if they do not leak, they are collaterals become happy. Say praise the Lord. But if they do end up leaking, you take your laser gun and you start shooting the hell out of those extra new vessels. After doing this IVFA, have I ever taken an OCT class for you guys? Did we do an OCT workshop so far? Okay.
No.
So an OCT is also extremely important for an RVO. I don't know if you guys have ever seen a CRVO OCT, but it is a very classic presentation. The main thing is it will have an IRF and it will have huge outer retinal tubulations. Okay, these two classic findings are there in OCT of CRVO. So you would also look for that. Why you want to look for an OCT is because you want to rule out macular edema, which is extremely common in CRVO. So why I am going on and on about every point is because not any point is without any reason in ophthalmology, and more so in these important diseases. I mean, I can just finish the class by saying OCT, FFA, but you might not have gotten the essence of why we are spending this much time with every investigation. This was not how I was taught, and I would have loved to have taught all the investigations like this. Like, what is the mainstay of the reason why are we spending so much time exposing the customer to, the patient to such a dangerous dye? Why are we exposing him to anaphylaxis and doing an FFA? Because what is going to happen in his eye is more dangerous. It's new vessels. So that way OCT is done to find out the extent of macular edema and also to confirm your findings. Along with that, IVFA you do after you have performed the complete ocular examination along with endoscopy. So this is your simple way of finding out. Another extra special thing also you can say, if anybody asks you how will you differentiate between an ocular ischemic syndrome and a CRVO, there is another very important investigation that you are supposed to know. I have never seen it being done in Abid or anywhere else. I don't even think anybody does it, but theoretically speaking, you should know this. This is one investigation that is very easy to distinguish between OIS and CRVO. Can you name it? So it is called as ophthalmodynamometry. So even though the name is extremely complicated and hi-fi. It very simply means the pressure in the arteries. Okay, and very simply put, where do you think the pressure will be more, CRVO or OIS?
CRV.
So Ali is saying OIS and Fabian is saying CRVO. So I thought it was going to be obvious, but if it's not obvious, what happens in OIS is there is carotid stenosis, and after that stenosis, the pressure in the carotid artery is not as much. Whereas if it's a CRVO, the pressure in the carotid artery builds up, and the CRVO, the pressure is very high. So ophthalmodynamometry will help you distinguish between the pressure in carotid artery. If it is high, it is CRVO. Okay. So. What else can you do? You can also perform some systemic investigations, fasting blood glucose, BP, check the pressure. If it's a younger patient, like I told you, right? Always the etiology. If it's a younger patient, it is always hypercoagulable state or autoimmune diseases. So autoimmune disease means what should you always test for? Simple tests. You should always test for ANA. ANA will be anti-nuclear antibody. Then you should always test for rheumatoid factor. Okay. Along with that, since it's a young guy, you should always also think about a STD. So you can also check him for syphilis, which is a VDRL or an FTA ABS testing. Okay. Always distinguish in your mind what if it's an old CRVO and a young guy's CRVO. Means try to think like this, and your investigations will automatically come to your brain. Also, hypercoagulable states, also factor V Leiden mutation testing, protein CNS levels, and other things like that for younger patients. Whereas if it's an older patient, think glucose, think HbA1c, think cholesterol, and CBC, other things like that. Okay, having said that, how do you treat this patient? So it's a young girl who's coming to you. Young married girl. So you have to stop the OCP. They will trick you, Kevin. They will trick you like this. They might not tell you the age, they might just show you the photograph, and during the time when they are starting to ask you questions, they might suddenly make up a new story of a newly Naveli Dulhan, and suddenly she is young, suddenly she is married, so you will be confused. Think always OCP. You guys remember, right? They have some albumin binding protein, and they reduce the albumin binding protein in the plasma, which reduces the free flowing thyroglobulins. I just forgot a few things. There was some mechanism. Basically, OCPs will cause more venous occlusion. So stop OCP should be the first thing. Second thing is, if his IOP is high, control the IOP. Third thing is, if you see an NVI or an NVA or an NVD or an NVE, what are you supposed to perform? PRP. Immediately. Do not hesitate even anything. Don't worry about the macular edema. Don't worry about the other eye BRVO. Don't worry about anything. The most important thing you should be worried about in diabetic retinopathy and CRVO or any RVO is NV, and for that you are supposed to perform a PRP. Having done that, you are also supposed to give the guy an anti-VEGF along with the PRP, which are very effective. How much they can be given, we'll discuss them slightly later. Okay. What if the patient is having a macular edema as well? How will you treat this patient? CRVO plus macular edema, no NV. So whenever you think of macular edema, no, I'm asking.
Anti-VEGF.
Yes, anti-VEGF is the correct answer. Can you tell me Can you tell me what is the dosage of antibiotics? Do you have a code?
No.
Okay, I'll help you out. After this, you will never forget. Okay. The thing is, it's very simple. It's a very nice. Alia, I hope you are listening. There are basically three ways to treat. What do you call this? Macular edema. Okay. The first way is ranibizumab 0.5. Okay. We very rarely use ranibizumab in Abid or Al-Salama or India. What we use is bevacizumab. But don't get confused. Anywhere it is asked, you always mention ranibizumab. Do not mention bevacizumab because bevacizumab is banned in UK. When I was in London, I had asked this question. Why is it that it is banned in the UK? They had no good answer. Basically, the good answer is the pharmaceutical companies have lobbied very nicely. I can't see either of you. The pharmaceutical companies have lobbied very nicely because bevacizumab is a cheap drug, whereas ranibizumab, Lucentis, is a very expensive drug. So they make a lot of money, the pharmaceutical companies, by selling Lucentis. So effectively, they have reduced bevacizumab only to be used for cancerous conditions. Some tumors they use bevacizumab, but I'm not sure which conditions. So if you say bevacizumab, you are not wrong, but you have to mention that they are used off-label. Okay. But if you want to give just one correct answer, you can say intravitreal ranibizumab. Okay. Now I'll tell you what the code is. It always starts from 0.5 mg. Okay. There is intravitreal ranibizumab 0.5 mg. But it is very expensive. That is why even in Abid also we give bevacizumab. We very rarely give Lucentis. Ranibizumab is Lucentis and Avastin is bevacizumab. So ranibizumab 0.5 mg is given if the patient is a Rani, means patient is rich. Okay, is it easy to remember? Rani will take ranibizumab. Rich patient will take ranibizumab, expensive drug, Lucentis. You go and ask Rajesh sir, I think it is something around 12,000 rupees per injection, whereas Avastin is 6k. I think so, 6k, sometimes 45, sometimes 55, I'm not sure. So if the patient is rich, Rani 14,000. So if the patient is Rani, you can give ranibizumab 0.5 mg. During my time it was 12k. Anyways, so Abid is growing. So ranibizumab 0.5 mg as the first mainstay of drug. Never ever skip this answer. After this, next you can say
0.5 mg per ml, right?
Yeah, 0.5 mg per ml. So you start with intravitreal ranibizumab 0.5 mg. The next drug that you can give is Ozoodex. So what is Ozoodex? Is it an injection? It's an implant. This distinction has to be made in your brain. This is dexamethasone biodegradable implant. How much Ozoodex is given? 0.7. So Rani was how much? 0.5. Ozoodex is how much? 0.7. So it is slightly increasing. So here the patient is neither rich neither poor, somewhere in the middle. You can give Ozoodex. But there are some complications that can arise with Ozoodex, such as all complications associated with steroids, which can be PSC, which can be IOP. Okay, that is why you always in Beta or Salama, we always prefer ranibizumab or bevacizumab. We very rarely go for Ozoodex, but we do use it. So ranibizumab was 0.5, Ozoodex is 0.7. What is the last thing if the patient is poor? Not at all. He can pay money, or it's like, we just want to somehow save the patient's vision. We give the patient IVTA or intravitreal triamcinolone. That is 1 mg. So the way you need to think about this is, as the drugs are getting weaker and weaker, the best drug is only 0.5 mg. Then you have Ozoodex 0.7 mg. Then the least preferable drug is intravitreal triamcinolone. We have to take 1 mg of it. Okay. Some people used to give 4 mg. I'm not sure how many mg Rajesh sir gives. Between 1 mg and 4 mg. Only remember 1 mg for now. Okay. Because if you say 4 mg, you will be wrong. So better to say 1 mg only. So to make life easy, macular edema can be solved by 3 ways. If the patient is a Rani, give her ranibizumab only 0.5 mg. If the patient is somewhere in the middle, give Ozoodex, which is a biodegradable dexamethasone implant, which is now 0.7 mg. If the patient is extremely poor, least preferred is IVTA, but the dosage is 1 mg. I hope this is simple. At least relatively simple. Better than not knowing anything.
The Avastin is also 0.5.
Sorry? What did you say, Kevin?
Avastin is also 0.5.
Avastin is also 0.5. Yes.
The Avastin, dosage of Avastin?
Yes, 0.5.
Oh.
To make life simple, ranibizumab and bevacizumab is 0.5. I am not getting into the habit of again and again repeating bevacizumab because, just don't say it. Say ranibizumab. Nobody will bother you. You can say bevacizumab as well, but they will expect you to know that it's an off-label use because legally भी ना नहीं इस्तेमाल करते. Nobody uses bevacizumab. मतलब on paper नहीं है. People use it all the time because it's cheaper and we can make good money on it, but it is not preferred or embraced so easily. So, is it simpler now? Macular edema, this so-called maze of labyrinth of all this anti-VEGFs and all those things, they are slightly easier right now. Intravitreal ranibizumab 0.5, Ozoodex biodegradable implant 0.7, intravitreal triamcinolone 1 mg. Now the reason I was mentioning 1 mg and 4 mg, just find out what Rajesh sir does and tell me next time, is because there was another study done. This study was called SCORE study. SCORE. In SCORE study, they found that intravitreal triamcinolone, when used in poor patients, 1 mg was as good as 4 mg, and it was having less side effects because obviously more steroids, more side effects. So why the hell will you spend your time or expose the patient to a 4 mg dose? You will not. So this point can be very nicely asked to you guys. What would be the dosage? So dosage is actually important. Dosage is not just wasting your time. Dosage is actually important because there are 3 studies only to do with dosages of anti-VEGFs. So the dosage of IVTA 1 mg is there for a reason. Just find out what Rajesh does. Having said that, the dosage for intravitreal ranibizumab and bevacizumab were also discussed in another study called CRUISE study and BRAVO study. Now in these studies, as the name itself suggests, CRUISE means CR, means CRVO. Lucentis used in CRVO. Did it help macular edema? So when the study was done, when they used, I think it was 329 patients. So when the study was done on CRVO patients by using 0.5 mg ranibizumab, they found that macular edema did resolve. This is CRUISE study. The same study when it was done in BRVO, it is called as BRAVO study. BRAVO. 0.5 mg ranibizumab. Can it resolve macular edema? Yes, it can resolve macular edema. So CRUISE study, Lucentis 0.5 mg. BRAVO study, Lucentis 0.5 mg BRVO. SCORE study, IVTA 1 mg is the outcome. You need to remember things like this. 1, 1, 1. If you make studies unnecessarily complicated, trust me, on the day of action, you will 100% forget it. You need to make the studies condensed as they are. They can be repeated in your brain in one line. And similarly to the examiner himself. What other studies did we discuss? CVOS and BVOS. So BVOS tell you that PRP is an effective tool for new vessels when they are seen in a BRVO. Whereas you also saw that CVOS told you that prophylactic PRP is useless. Don't do prophylactic PRP in CRVO before you see signs of NV. So this is a seemingly simple topic like CRVO can have so many questions. So next time I show you guys a photograph of CRVO, I'm hoping you guys will ace the Viva without any hesitation. VRVO is somewhat similar. I don't know if anything is different in VRVO, inshallah. Apart from what else? What is different in VRVO? Yeah, apart from focal laser, like Alia was mentioning, for some reason focal laser is extra in VRVO. Before you do PRP, you perform a focal laser in VRVO. That's the only difference in the treatment. So I won't spend too much time with VRVO, but just to give you guys an idea, since I will just show an image of VRVO. Fabian, just please check your masterclass.
Yeah.
Did you get it? Now, do you understand why I was hesitating to accept your STBRVO answer? Because it is extremely clear that they are so different. I mean, in a way, if you think about any disease looks like every disease. But from an ophthalmologist's point of view, the examiner's point of view, he will never accept your answer as STBRVO. Because if you see scattered hemorrhages, like you said in your own words, just say it most probably looks like a CRVO to make life easy for you. Okay, so this is how clearly STBRVO differentiates or differs from a CRVO. I think we have nicely covered CRVO. I don't think there's anything remaining. Yeah, I think that's it. I think that's about it. BRVO also we have, I would say for the most part we have covered. Only one thing different in BRVO is you are supposed to do a focal laser before you start a macular edema treatment. Before you do ranibizumab, that bevacizumab, all those things, you start a focal laser first. And follow up. I forgot follow up. Will you let this guy go away, Philip, after you have done? Actually, you have not done anything. There's not much you can do. Today, there is no macular edema. Today, there is no new vessels. You see the guy's eyes. You send the guy, you classify him as ischemic or non-ischemic CRVO. Okay, non-ischemic CRVO and ischemic CRVO. What will you do?
Yeah.
Who will you call how many times? Let's start with non-ischemic CRVO.
Ischemic CRVO, I think it's better to call on a monthly basis for 5 to 6 months.
What did you say? Monthly basis?
Monthly basis for ischemic CRVO.
Yeah, it's very simple. Ischemic, call him monthly for how many months?
5 to 6 months maybe.
Yeah, 6 months, because 7th month is generally the point at which the new vascularization onset happens.
Yes,
so you are trying to monitor him for, one is new vascularization. What is the other thing you are trying to look for? Yeah, macular edema. You are also trying to look for macular edema. What is the third thing you are trying to look for in ischemic CRVO? No, that comes under NV only, Alia. NVA, NVD, everything that comes under NV. No, the third thing you are trying to look for is the risk for fellow eye. The risk for fellow eye also developing a BRVO or a CRVO, which is 10%. Yeah, RD, everything could all result from macular edema and new vessels themselves. So I would not exactly call the patient back for an RD. If you say it, you're not wrong, but main is your NV, your macular edema, which are definitely going to happen, and 10% chance of BRVO in the fellow eye. So this is what you're going to follow up the patient for if it's an ischemic. If it's a non-ischemic, then 2 months. Call him every 2 months. But either way, do call him after every in the 6 month duration. This will complete your answer for CRVO. Okay, buddy. I think we are good enough today. Okay then, we'll call it a day. Why don't you guys go and rest? Seven really looks like he needs the rest.
Yeah.
Is it okay, buddy? Are you having an allergic reaction?
Yeah, it's just a cold.
Oh my god. Okay, fine. You can leave, Seven. Alia, you can leave as well. I'll see you guys
Yeah.
tomorrow, or maybe I'm on leave. I'll just let you know, okay? Take care. Bye.
Okay.